Uh, a very good evening, everyone. And today, on the World Hypertension Day, it's been a great opportunity. And we have with us a very renowned speaker to share. And it's been a pleasure to have him always and share a dais or share a workshop with him. And there's a lot of learning every time that we have sir with us. So Dr. Arun Maya is there with us today. And I welcome him on behalf of CVPR Society. To continue the proceedings for today, I hand over to Dr. Ankita Asher to introduce Dr. Sudeep Kale and take it forward from there. Over to you, Ankita.
Thank you, ma'am. Good afternoon, everybody. Welcome to the Zoom meeting on exercise and hypertension. Dr. Sudeep Kale is with us, who will introduce you to Dr. Arun Maya. And all of us are aware about Dr. Sudeep Kale. He's a very active, young, dynamic physiotherapist. And I think words are too less to introduce him to the group here. But nevertheless, he's the newest appointed secretary of Society of CVPR. So I hereby hand over to Dr. Sudeep.
Thank you and good evening to all. It's an honor for us to have Arun Maya sir with us on World Hypertension Day. I appreciate Society of CVPR for addressing the issues and contributing in the public health and the awareness on this day and issue. To introduce Arun Maya sir, if I will go as per the CV, I will take minimum 30 minutes. So I will try to introduce in few minutes because we want to hear him on the topic. Arun Maya sir does not need any introduction. He is one of the pioneer physiotherapist who is working in this CV cardiorespiratory sector. Currently, sir is Dean of Manipal College of Health Sciences, Professor of Physiotherapy, Physiotherapy Head in charge of Cardiopulmonary Unit 1, in charge of Diabetic and Laser Clinic at Manipal. He is a PhD guide. He is a Chief for Center of Diabetic Foot Care and Research at Manipal. He is a PhD holder and also he holds MBA in healthcare. Sir has more than 25 years of experience, clinical, academic, administration, research, and has many more publications. You can visit sir's profile on ResearchGate, LinkedIn to know about all the researches, because if I will speak, I will take many time. Thank you, sir, for being with us. Over to you, sir.
Thank you, Dr. Sudeep and Dr. Maria Madam. Thank you for inviting me to deliver a session. It will be a great honor for me to interact with all of you. And I would like to compliment the Cardiovascular and Pulmonary Rehabilitation Society under the leadership of Dr. Sudeep as well as Dr. Maria. I wish a great success, and actually it is a very essential and the need of an hour to start this society in India to strengthen the cardiopulmonary rehabilitation for the needy populations. Once again, thank you and greetings on the occasions of the World Hypertension Day to each and every one of you. Is my slide visible?
Yes, sir, it is.
Visible, sir. Sir, slide.
Okay.
Yeah.
Okay. Once again, very good afternoon to all of you. World Hypertension Day greetings to each and every one of you. Today's topic of my presentation is focusing on the assessment and management of hypertension from the rehabilitation's point of view. As all of us know, across the globe, 17th May is considered as the World Hypertension Day, basically to create an awareness to the public as well as to strengthen the healthcare professionals, those who are working in the field of the cardiopulmonary conditions. This year's the theme is measure your blood pressure accurately, control it, live longer, with an emphasis on addressing low awareness rates globally, particularly to low to middle income areas, and accurate blood pressure testing technologies. That is also very, very important. Not just monitoring, we need to monitor with the right gadget so that the identification, the diagnosis, and the monitoring of the patient needs to be appropriate. As all of us know, the systemic arterial hypertension constitute as one of the significant contributors to the non-communicable disease spectrum. When we say the non-communicable disease, hypertension, diabetes, obesity, cardiovascular disease, cancer, stroke, and the chronic pain and all, among all these non-communicable disease, the hypertension play a significant contributions to the non-communicable disease spectrum. World Health Organization represent or the reports systemic hypertension accountable for almost 45 to 51% of mortality from the heart disease and the stroke worldwide respectively. The prevalence has been reported to be higher in urban as compared to the rural area. This is mainly because of the change in the lifestyle. All this disease, even though we call it non-communicable, but predominantly we call this disease as the lifestyle disease because the prevalence or the increase in the reporting of these conditions are predominantly because of the change in the lifestyle. When we say the change in the lifestyle, it could be due to an abnormal diet pattern or irregular diet pattern, lack of physical activity, and the stress. And another important aspect, as the urbanization, there is a modernization and the mechanization that further decreases the physical activity of an individual. So the global action plan by the World Health Organization for the prevention and the control of the non-communicable disease is basically to reduce the prevalence of the diabetes and the hypertension, because these two are the interlinked. Someone is diagnosed with the hypertension, they are prone for developing the diabetes also, because one of the important contributing factors for these two diseases is an increase in the fat, especially the visceral and the subcutaneous fat. So subcutaneous and the visceral fat increases leads to an insulin resistance. This is prone for both hypertension and the diabetes. The estimated proportion of disability adjusted life years attributable to NCDs in India has risen from 31% of total DALI in 1990 to 55% in 2016. Almost you can say that 25% increase in these things has a significant impact on the morbidity and the mortality of the populations, mainly because of the non-communicable disease. So this is a simple message all of us needs to know. Basically, a blood pressure created by a heart as it pumps blood through the arteries and the circulatory system. All of us know the systolics and the diastolic. Sometimes this is also a silent killer because most of the patients are asymptomatic. When they develop a subarachnoid hemorrhage or other associated or the significant myocardial infarctions, the patient comes to the hospital with the severe illness. When they are screened for other comorbidities, the hypertension is usually used to be detected as one of the leading cause for this. Sometimes they also may manifest with the blurred visions, chest pain, and the headache. The exact cause for the primary hypertension is not very clearly defined, but predominantly secondary hypertension is related to the kidney abnormalities, narrowing of the most commonly the atherosclerosis. Sometimes could be due to the pulmonary tumors, adrenal gland abnormalities, or the pregnancy. Lifestyle factors like the salt intake, obesity, alcohol, stress, and the lack of exercise are the contributing factors. So it is important for us to know this classification. When do we call normal? When do we call elevated? When do we call high blood pressure stage 1, stage 2, or the stage 3? Normal, you all of us know 120/80. Anyone between 120 to 129 or less than 80 is considered to be pre-hypertension. Normally, we call them as pre-hypertension. Anyone with 130 to 139 or 80 to 89 is the stage 1. More than 140 or 90 is stage 2. And more than 180 or 120, irrespective of the age, is considered to be hypertensive crisis. So the screening from the rehabilitation point of view, the screening play an important role in the early detections for the hypertension. Not necessary that you have to diagnose them only when they develop the 130/85 and above. Suppose if they have any contributing risk factors, that is actually a warning sign. So there itself you have to provide a proper education, and we have to highlight about the risk for developing the hypertension. So there are three important factors. Maybe I request the delegates to mute yourself. These are the three key factors we need to start screening in the early age. Earlier literature used to say that more than 45 years of age, usually the people needs the early screening. But now, because of the modernization, mechanization, lifestyle change, even 25 years and above is an important age risk for developing the non-communicable disease. Therefore, ideally from 30 years and above, it is important for us to screen for three aspects like the physical activity level, nutritional habit, and the body composition. This needs to be a part of our evaluation in every healthy individual. Sometimes they may be healthy, they may be asymptomatic, but it's important for us to detect or screen for these. And if you are ignoring this, they are the strong modifiable risk factors for developing either hypertension or the diabetes. Then another important aspect is the metabolic syndrome. Most of the time we ignore this in our routine clinical practice. One important aspect is any individual with, especially the male, with more than 88 centimeters of the waist circumference or female with more than 80 centimeters of waist circumference are the strong risk factors for either developing hypertension or the diabetes. Usually they say it is a span of 6 years. Today, if you screen an individual with 30 years age, he may be having or she may be having a waist circumference more than that. If the appropriate preventive strategy is not taken, then by the next 5 to 6 years, they are prone for developing a pre-hypertension or the pre-diabetes. Therefore, in the healthcare system, diagnosing the metabolic syndrome is a very, very important for the cardiopulmonary physiotherapist. When we say the diagnostic for the metabolic syndrome, any three factors needs to be positive. One is the most strong, the strong predictor is the waist circumference, then is the diabetes or the hyperglycemia or the hypertension. Out of 5, if any 3 are positive, they are considered to be a metabolic syndrome. When we go for the body composition, there are multiple methods by which we can screen. I will not go into the details of this. Basically, it is important for you to stratify the fat mass and the fat-free mass. This is an important point. When you look for the body compositions, you need to identify these. Most of the time, in the clinical practice, we focus mainly on the fat mass. But the fat-free mass also play an important role. You must have seen in your routine clinical practice, a lean person, if you identify, they may be having higher triglyceride, they may be having higher cholesterol, not necessarily they are obese. But if you look at their fat-free mass, usually it is less than the reference range. Therefore, when you look at the body composition, always identify the fat mass. When we say the fat mass, it is important to know the subcutaneous fat as well as the visceral fat. Fat-free mass, we need to look for the muscle mass. The fat mass is basically the visceral fat needs to be less than 9%, and the subcutaneous fat needs to be less than 25% in male and less than 28% in female. And most importantly, the fat-free mass or the muscle mass ideally needs to be more than 25%. If it is less than 25%, even though they don't have the higher fat mass, but these people are prone for developing either dyslipidemia. Dyslipidemia is also one of the strong risk factors in lower fat-free mass people. Therefore, it is important for us to identify both fat mass as well as the fat-free mass. According to the classifications, all of us know this, and the method of screening also all of us know. Any 3-site measurement needs to be done when you are looking for the subcutaneous fat, especially using the skin fold caliper. Any 3 area needs to be detected, either the triceps, biceps, or either in the iliac crest or the abdominal region, or either you can go for the 7-site measurement. The next important thing is looking for the body composition analysis, especially the bioelectrical impedance instruments. And there are different types of instruments are available. As I mentioned in this, one of the advantages you can able to differentiate fat mass as well as the fat-free mass. Then the next important aspect is the central blood pressure devices. It's a non-invasive central blood pressure measurement. It is important to it is not just recording only the systemic blood pressure of an individual. It also helps in identifying the central blood pressure or the amount of the load, and each beat the cardiac system is working on pumping the blood in each beat. Then the next important aspect is the assessment of the physical activity. As a physiotherapist, this is the important aspect. We need to give a lot of importance in our routine clinical practice. So all of us know the physical activity and the exercise. Physical activity is basically an increase in the energy expenditure above the baseline, basically because of the contractions of the various group of muscle. Whereas the exercise is the subcomponent of the physical activity. Basically here important for you to stratify when you use the pre-participation screening tool, identify the risk, the PARQ-20, all of you know how exactly we can able to stratify them as low risk or whether they are risk free. If they are yes to any of the 7 questions, ideally we say that they are prone for, or they need to go for the further medical evaluation. Another common tool is basically the ACSM health or fitness facilities pre-participation screening tool. Here we, based on the sign, symptom, and the positive risk factor, we have to stratify them as low, moderate, or the high risk. Basically what we do is the individual with various risk factors, age, gender, and associated positive risk factors, negative risk factors, and also based on the signs and symptoms, we stratify them. This is important for us to go for the further evaluation. What type of exercise testing we need to do before we go for the exercise prescription. Then the physical activity can be, basically you need to look at the frequency, duration, intensity, and the type. There are various tools are available. All of us know the International Physical Activity Questionnaire, IPAC, long and short. And most commonly in Indian populations, it's important to use the Global Physical Activity Questionnaire, which has higher sensitivity looking at the cross-cultural applications. Based on the Global Physical Activity Questionnaire, it is important for us to stratify them that whether they are low, moderate, or the highly physical active. Based on all of us know that anyone with less than 600 met minute per week, usually we call them as the low. Anybody with less than 300 met minute per week, usually we call them as sedentary. Anybody with more than 600 met minute per week, usually we call them as physically active, and then accordingly we stratify physically very active or the highly active. It depends upon the self-reported met minute per week of physical activity. In addition to the physical activity screening, especially in younger population, as I mentioned, 30 years and above, when we are screening, look for the sedentary behavior. most of the time when they report the physical activity, if they walk for a 30 minutes per day of moderate to high intensity exercise, if they perform, when you calculate the met minute per week, usually you consider them as the physically active. But if you are not knowing the time of their physical activity level, especially if they are IT professionals, predominantly they sit and do the work for more than 5 to 6 hours per day. So their sedentary nature is increasing as compared to they may be the physically active. So that it is important for us to know whether what is their sedentary nature and what is their physical activity profile. There are various tools are available. Accelerometer has the import as compared to the pedometer. It helps in quantifying the activity level, including the sleeping hours of an individual for a 24 hours. Then the another important aspect is not only looking for just the physical activity level, not only looking for the body composition, it is important to understand the metabolic activity of an individual. If the metabolism is hampered due to the other factors, sometimes in clinical experience, based on our clinical experience, we see some patients comes and tell you that I am doing a regular exercise for 30 to 45 minutes every day, but I am not losing any weight. One of the contributing factor is their basal metabolic rate. Therefore, along with the exercise screening, along with the physical activity screening, along with the body composition screening, it is important for us to know the metabolism. Metabolism has factors like age, gender, body composition, diet, exercise, stress, disease, and so many other things. What is the daily activity, sedentary life, activity versus busy, exercise, the type of exercise. Then the next important thing is the thermal effect of the meal. Basically, the nature of the food, the gap between the two meals. Why this is important is, if you take 100 kilocalorie of the food, ideally the 50 to 65% is required for our basal metabolism. The 10% immediately after the food for a first 1 hour, or the immediately after the food after 1 hour, it is used for the thermic effect of the food, basically for the digestion. And the remaining goes for the 30 to 50% burns through our physical activity. If their basal metabolism is low, this is one of the contributing factors for developing the risk. Or sometimes we also say the gut health. Most of the time now we give a lot of importance to the gut health also. That ideally, sometimes the lesser amount of blood supply is provided to the thermic effect of the food or for the digestion. This is one of the contributing factors for the abnormal changes in the body composition. Most predominantly, like examples like we have the IBS, irritable bowel syndrome. This is one of the common factors where the thermic effect of the food get disturbed. In those cases, their basal metabolism is usually low. In those cases, what we need to focus is, you may have to go for the sustained, I won't call it as a continuous, or the intermittent, the enhancement in the physical activity level. It should go a little slightly more than the 50%. So all of us know how to calculate the resting metabolic rate. You no need to have an advanced exercise testing protocol to calculate the metabolism of an individual. This is a well accepted general formula based on the 1 calorie into body weight into 24 hours. Usually you will be able to calculate the basal or the resting metabolic rate of an individual. The usual range for a man is up to 1,200 to 2,400 kilocalorie per day. This is important for us to calculate in the initial screening to understand the metabolism of an individual. Then we have a various clinical exercise test. Is the next screening level. We can perform 6 minutes walk test. Depends upon the patient's other comorbidity and the other risk factors. Or we can progress to the shuttle walk test, or you can also go for the cardiopulmonary exercise test. This is an we need to take a call, depends upon the individual's finding based on your initial screening. So I will not go into the each exercise test protocol. Basically, most of the time we see the elderly population more than 60 years and above with multiple comorbidity. Like they may be having hypertension, diabetes, they may be having other neurodegenerative disorders like osteoarthritis or any other associated thing. In those cases, in the safer side, before you start prescribing the exercise, ideally you can go for a 6 minutes walk test, and accordingly you can plan your exercise program. In addition to this, in the hypertensive patients, suppose if they are, usually we call it as a hypertension resistance. Hypertension resistance means even with the medication, even with the change in the lifestyle, sometimes they are not responding to that properly. In those cases, either Holter monitoring or assessment of 24 hours of ambulatory blood pressure is very, very essential before we go for high intensity exercise. Predominantly, this is 55 and above. Suppose if the patients are not responding to your initial prescriptions of exercise protocol, even with the pharmacological agent, one of the problems may be due to the cardiac or due to the insulin resistance. That also will not allow the blood pressures to drop. Not just for insulin resistance is not just focusing only on the diabetes. It's also one of the strong predictor for not like helps in reducing the blood pressure. In those cases, now as a cardiopulmonary physiotherapist, we also can do this testing, or predominantly cardiologists perform this. And other advanced things like physical performance, vascular compliance assessment can also be done, and then the cardiac index. This all of us know that. Basically, the vascular compliance is basically an extensibility or the distensibility of the vascular system. Either it may be the peripheral vasculature or the coronary or the central vasculature. It's important to know how much the changes, the vessel wall compliant or the changes during the activity. This is also an important aspect to control the hypertension. The next important thing is the cardiac index, basically a parameter related to the cardiac output from the left ventricle in 1 minute of the body surface area. So these all the factors, sometimes we may have to go for an advanced assessment in the hypertensive patients. So what the management needs to do? The management needs to start with the proper education. The medication is not only the solution for the controlling the hypertension. Most important thing is a proper education, proper lifestyle modification is very, very important. Basically, if they are overweight, the gradual or the steady losing of the weight is important educations we need to provide them. Not most of the time what happens is the people will say they have been diagnosed with hypertension, immediately they go for losing the weight. That is also not good practice, because you are not losing the fat, you are just focusing on losing your muscle mass. That's also not good. So the steady decrease in the weight loss, you need to have a clear plan for the next 3 weeks, 3 months, next 6 months, next 1 year. What should be your objective in losing the weight? In terms of promoting the physical activity, risk factors modification, management of the stress, and a healthy diet in terms of salt restrictions and other aspects. This is a one slide usually we highlight, like what is your objective of any prescription. Suppose if they are non-obese, your focus is mainly on maintaining the cardiopulmonary fitness. I call it as a maintenance. Basically, your objective should be 1000 kilocalorie per week of burning needs to be done. This is an initial target usually we need to provide in the sedentary people. Sometimes you have a body mass index of more than 28 and above. If they have another associated muscular problem, do not go for an aggressive exercise. You can go for an exercise of a minimum of 150 minutes per week, corresponding to a per minute calorie consumption of maybe you can say 5 to 7 kilocalorie consumption per minute. Approximately it will go up to 1000 kilocalorie per week. So that, or if they are very sedentary, first don't prescribe the exercise or physical activity promotion. Focus on breaking the sedentary nature. Unless you do that, you will not be very successful in implementing the exercise programs. So break the sedentary nature, or if there are sedentary individuals, low sedentary individual, try to focus on the energy use of about up to 1000 kilocalorie. If they are non-obese, if hypertensive, focus should be improving the cardiopulmonary fitness. Maybe you can go up to 1600 kilocalorie per week should be the second. The third category is if they are obese, along with that, your focus should be on management of the hypertension. You need to also to lose the weight, a gradual losing of the weight. Therefore, the target should be minimum of 2000 kilocalorie per week. This maybe all of you know this rationale. Normally what we say is 1 pound of fat is equal to 3000 kilocalorie. 1 pound of fat is usually 3600 kilocalorie. Your objective is to lose a 1 pound of fat, means a half a kg of the fat, nearly half a kg of a fat. They need to burn minimum 3600 kilocalorie. It is not possible in 1 day, 2 days, or 1 week of practice. Minimum 2 weeks of training is required to lose nearly half kg of fat or the half kg of fat. This why I'm stressing this point is most of the time we highlight this. As I mentioned, the people will go for an abrupt, a quick weight loss. They go for a starvation diet. They go for different alternative approaches. That is basically they lose the muscle mass or the muscle protein or the body water. They are not losing the fat. This education is very, very essential when we are prescribing the exercise. Exercise is yes, medicine. It makes lot of wonder, lot of benefit will be there, but it takes time. This education needs to be provided to the people. They cannot able to expect some 1 or 2 weeks drastic change in their body compositions or the other benefit. Because our focus is to improve the efficiency of the muscle. At the same time, our focus is to reduce the subcutaneous and the visceral fat, thereby you prevents the or delay the progressions of any of these lifestyle disease. So systemic hypertension is treated through the medical management, which includes antihypertensive drug. We always need to synchronize our exercise prescriptions with the medication. This is very, very important. Then the benefit will be always more effective. Always synchronize with the medication and the exercise. Lifestyle modification is the second approach, which include appropriate diet, regular exercise, health education. To undergo an aerobic exercise of 3 to 4 sessions per week or 40 minutes per sessions involving moderate to vigorous intensity to lower the blood pressure. This all the evidences says. The training principle should focus on this specificity, progression, overload, reversibility, and the right. This should be your gradual. You need to have a focus on the specificity training. There needs to be a steady increase in the overload. There needs to be a proper progression. This all the factor needs to be considered. This and the exercise also has a significant impact on the cardiopulmonary systems in terms of the output, in terms of the stroke volume, in terms of the heart rate, in terms of the blood pressure. This all the measurable and objective outcome measure to establish. It's already established in the clinical practice the benefit of a structured, proper exercise training on the cardiopulmonary or the cardiac parameters. So when we say the exercise, as I mentioned, sometimes you can see the patients with the various mobility issues. There may be, they have a severe osteoarthritis, they may be having the back pain and other associated problem. In those cases, basically, you can start with the chair-based exercise. Chair-based exercise is now found to be very effective in the workstation, especially as a preventive strategy many of the international organizations are recommending this exercise, basically because your objective is to break the sedentary nature. Even in a healthy individual, if they are working work stay is a continued or the executive job or continued to sit for longer duration of 6 to 8 hours per week per day, then you can tell them that every 45 minutes, 1 minute of spot march. Usually we call it as a spot march for 1 to 3 minutes, or chair exercises can be recommended. Thereby they can break the sedentary nature, or this can also be used in individuals with the severe mobility problem. The many evidences have highlighted that over time, this helps in reducing the blood pressure as well as losing the weight. How much should our patients take? The recommendation says normally more than 30 minutes, more than 20 minutes of vigorous activity. And in the beginning, always we need to, simple recommendation is 30 minutes of moderate activity 5 days per week. Minimum of 5 days per week needs to be an initial recommendations. What the evidence says, what about the various types of exercise in terms of the isometric exercise, isotonic exercise, strength training, what the evidence says with respect to the management of the hypertensions with the exercise. The present data suggests that strength training performed with the moderate to vigorous load intensity, a minimum of 2 or 3 days a week, performed at least 8 weeks, is a good strategy to decrease the blood pressure in hypertensive individual. When you go for the strength training, always focus on the larger group of muscle. Select the upper extremity and the lower extremity muscles as well as the 1 or 2 core muscle. A minimum of 8 to 10 repetition is required, and a minimum of 6 to 8 set of exercise is required. Means minimum of 6 group of muscle needs to be involved in the resistance training in each session. This has a significant impact on the management of the hypertension. Generally, the regular exercise makes the heart stronger. Stronger heart can pump more blood with less effort. This is the most important objective in the hypertensive patients. All this exercise training, when the peripheral muscles are improved in terms of cross-sectional area, in terms of the strength, in terms of the endurance, they put significant lower load on the cardiac system. Thereby, heart can able to function effectively. Thereby, it can prevent the consequences of the stroke or the myocardial conditions. The mechanism, how exactly the exercise helps in changing the blood pressure. The most important thing is effect of aerobic endurance exercise training has a significant effect on the resting hemodynamics. As I said, in terms of the cardiac output, in terms of the stroke volume, in terms of the resting heart rate and the resting blood pressure. In addition, decrease in the activity of the autonomic nervous system is the most important parameter, especially the sympathetic and the parasympathetic change, is the most important factors for reducing the blood pressure, helps in decreasing the systemic vascular resistance, thereby lowering the plasma norepinephrine and the plasma renin activity. Thereby, it helps in controlling the angiotensin mechanisms or the renal regulations of the blood pressure. Another important aspect is decrease in the insulin resistance. Also contribute to the effect on the lower blood pressure, because as the insulin resistance is reduces, the fat demand is, the blood supply to the fat is also gradually comes down. Thereby, it reduces the load on the heart. Next important thing is improvement in the endothelial function. Is another important potential mechanism based on the exercise. In addition, the hypertension also has on the heart. Hypertension is frequently characterized by the pathologic left ventricular remodeling with the concentric hypertrophy. So this is the one of the reason for a long-term effect of the poor ventricular function, poor ventricular, you can see the abnormal dilatation of the left ventricle. Thereby, there is a pooling of the blood in the left ventricle, but it is unable to eject there or pump out, so that the lower ejection fraction that leads to the heart failure or it also has a significant impact on renal systems and the neural system. So by Laplace law, all of us know this. The response to the hypertension is initially adaptive with the increase in the wall thickness to decrease the wall stress and the oxygen demand. Exercise also has a significant impact on this cardiac function. Then the physical activity benefit on the heart, it basically helps in eccentric left ventricular remodeling and also helps to increase the volume. And isometric exercise is typically characterized by the concentric left ventricular remodeling without chamber enlargement in response to the increase in the systemic vascular resistance. Therefore, we usually say the smaller group of muscles, the isometric or the static exercise is not recommended in the hypertensive patients. Then on the cardiac remodeling, reductions in the left ventricular mass index, significant reductions in the systolic and the diastolic blood pressure, and also helps in improving the functional capacity. These are all the benefits of exercise on different aspects in terms of the cardiac system, in terms of the musculoskeletal system, in terms of the molecular level, in terms of the biochemical level, in terms of the cellular mechanism. So exercise is found to be effective, not just only on the subjective reporting of the patient, not just only on the quality of life, not just only on the function. Exercise also found to be effective even in the structural changes or the remodeling. Therefore, it is important that in the scientific or in the clinical practice or in the multidisciplinary team, we can very confidently say that this needs to be one of the important standard line of management in the diabetes and the hypertensive patients. Contractility and the calcium handling also, there is an exercise has an important benefit. And how much is the, and in terms of the body composition, the lower body mass index also helps in reductions in the systolic blood pressure. How much is the clinical significance? Most of the time patient also will ask you, we also need to know. A decrease in the a minimum of 6 millimeter of mercury and a decrease in the 1 to 3, even though I mentioned 1 to 3, even the 1 to 3 drop in the diastolic blood pressure is having a lot of clinical relevance. It helps in controlling the hypertension. It also significantly, almost you can say about 20 to 29% of reductions in the cardiovascular risk and the stroke risk. So diastolic of 1 to 3 drop is ideally you can expect these changes in a matter of minimum of 6 weeks to 3 months of training. Especially in the obese individual, it may take little longer duration, 3 months and above. Otherwise, it is this much of change is clinically important from the exercise benefit point of view. Okay, clinical implications of the hypertension. So today is a World Hypertension Day. As I mentioned in the beginning of the presentation, this is a major public health concern. Therefore, it leads to the major burden on the healthcare system, strong predictor for the other complications like stroke and cardiovascular risks. Therefore, there is a need for early screening of body composition, customized exercise-based rehabilitation to prevent metabolic syndromes as well as the other related complications. What we can do? Most important thing is patient says, I have these facilities. But these all the gadgets are most of the time we see at home, it is used for other purpose, not for the exercise. Most important thing in the clinical practice is every patient, every visit, every treatment plan. In the comprehensive healthcare team, when they come to the physician, in every visit, they need to consult physiotherapist. Every visit, we need to assess their physical activity level. like other vital signs. We measure blood pressure, heart rate, and all other parameters. Especially in the non-communicable disease, physical activity level screening needs to be one of the important vital signs in the non-communicable population. And we must begin to merge the fitness industry with the healthcare industry. We need to recommend, we need to tell the patient what exercise gadget you need to use, not by the industry. Industry say you buy treadmill, but how if the treadmill is not used effectively? If the patient is having lumbar canal stenosis with hypertension, osteoarthritis with hypertension, if they buy the treadmill, whether they can able to use it effectively. That as a healthcare professional, we need to suggest them what is the mode of their exercise regime. Summary, physical inactivity is the major public health concern. As a clinician, we have the responsibility to assess the physical activity habit, inform the patients of the risk and prescribe the proper exercise. Where time allows, consider formal exercise prescriptions or the referral. Exercise is the medicine that we need to take and get patients to take. And next important thing is initially don't go for high. Always try to break the barrier. That is important. Understand the barrier of the patients, try to break the barrier, then they become more friendly. Otherwise, if we say, just go for 30 minutes of walk without understanding their daily routine, we'll not be able to successfully implement. At the same time, patients will not adhere to your prescriptions properly. Most important thing is, first try to change the barrier and then go for the formal prescription. Thank you all. With this, I conclude my session. Thank you all.
Thank you very much, sir. Sir, we have a few questions are there. So I will just ask one by one.
Okay.
The first question is that if the patient is obese and he wishes to decrease the weight more in less days, then how many calories can he target per day? What should be the calorie?
For example, as I said, the quick weight loss is not the fat loss. This educations we need to do to all our patients. A minimum of 6 weeks to 8 weeks of training is required to lose at least you can say about 1 kg of fat. If they lose 1 kg of fat, their body mass index, you can say about 3 to 5 up to 3 kg in general they will lose, because when they do the exercise along with the fat loss, they also lose the body water content. Thereby, when you measure the weight loss, you may see up to 3 kg. The most important screening what we need to do is, if they are obese, initially look at calculate their percentage of increase in their fat mass, and accordingly you educate the patient. Suppose if they have comorbidity, I think you mentioned that they also have a osteoarthritis, no? Something you mentioned, if I heard correctly. Obese and any other associated complications?
No, only obesity.
Obesity. Ideally, 6 weeks to 8 weeks is the minimum time required for them to bring some significant changes in the fat loss. I repeat, significant change in the fat loss, not the weight loss. If you go for starvation diet, if you go for any other approach, you may lose the weight quickly, but it is not actually the fat. Okay, a minimum of 6 to 8 weeks is required.
Sir, second question is that hypertensive drugs, antihypertensive drugs, whether they will have effects on exercise program, and if the patient is taking morning and evening drugs, then what should be our exercise timing and regimen?
Can you just repeat that? Can you?
The patient is on the medications for hypertension. Does that medication will affect exercise performance?
Does medication?
affects the exercise performance.
Okay. So what type of medication is important? Suppose if they are on beta blocker, ideally after 1 hour of their medication, especially in the morning time, after 1 hour of their medication, we can synchronize the exercise to these patients. Then the beneficial effect or the physiological effect will be much, much higher. Clear? 1 hour after the medications, ideally, they need to do the exercise. Ideally, they have to avoid exercise after 3 to 4 hours of taking of the medication, because that time it's a peak action of the medication. That time there is a significant drop in the blood pressure. At the same time, if you do the exercise induced hypotension is also can be possible. Clear? And if they are taking the exercise on both on the morning and the evening session, my recommendation is ideally you can suggest the patients to take the medications in the early morning. Ideally most of the time we say the hypertensive medication is to be taken between like morning 6:30 to 7:30 is the right time, either with food or without food also, because some medications will not trigger the gastric irritations and all. So that ideally they can take the medications and then they can synchronize the exercise. But it is not recommended to do the exercise in the initial stage both the time, because nocturnal hypotension may be one of the risk factors if you prescribe the exercise in both morning and evening. Ideally, first 6 to 8 weeks, prescribe the exercise in one session. Once they are adapting to that, suppose if you want to focus on weight loss and also we want to go for an aggressive lifestyle modification, you can advise the patients to do the exercise in both the sessions, morning and evening. Preferably evening before the medications they can take. No harm. Like ideally we recommend that 6 to 7 o'clock is the ideal time for performing the exercise, either in the morning or the evening, because it has a significant relation with your circadian rhythm. That's the time where if you do the exercise, that will have a significant benefit on the physiological system.
Sir, next question is that
Yeah.
the person is hypertensive and having diabetes as well as obesity.
Okay.
And tachycardia with lower intensity exercises. So in this situation, what should be the duration of exercise and target calorie burning and timing?
What is the reason for the tachycardia in this patient? Any other associated morbidity? I'm just giving a other possible hypothesis.
No details in the question.
We have to rule out the tachycardia, cause for the tachycardia. Sometimes in these patients, there may be a chances of the covert atrial fibrillation. That needs to be ruled out before you go for exercise. The second thing is, if they are obese, in obesity also, because of the deconditioning, their resting heart rate is also usually high. If it is associated with the atrial fibrillation, you need to stabilize and then only go for the exercise prescription. If the tachycardia is related to the deconditioning, then the first important thing is in the first 3 weeks, it is better to go with the low intensity exercise, a period of 10 to 20 minutes of exercise, focusing more on the larger group of muscle stretching, the low intensity exercise like not even the brisk walk, their self-paced walking. Once normally if it is because of the deconditioning, gradually the tachycardia will get stabilized. Then you can reevaluate and then prescribe the exercise according to based on your initial exercise test. I hope I'm clear with my answer.
Yes, sir. Yes, sir. Thank you. So the last question is that,
okay,
is it advisable to encourage physical activity to check BP response in resistance hypertension during BP monitoring? Is it advisable to encourage physical activity to check BP response in resistant hypertension?
So according to the evidences, irrespective of the staging, the exercise is indicated, but the intensity of the exercise, the duration of the exercise needs to be modified according to the individual's need. There is no, you can say, an absolute exercise is not an absolute contraindications in any stage of the resistance hypertension. When you say the resistance hypertension, with the medications or with any other lifestyle interventions, they are not responding. But in those cases, exercise is recommended, but the intensity of the exercise needs to be more, you have to take an appropriate caution before you prescribe. One of the important reason is because they have an abnormal sympathetic tone. So in those cases, the relaxation exercise works very well. In the initial stage, we can say the general stretching, synchronizing with the breathing, major group of muscle stretching exercise in different position. It may be supine, it may be sitting, it may be standing. Focus on first 3 weeks, synchronize the breathing with the stretching exercise. If you do that, ideally, you will be able to see a good change in the blood pressure response. That usually we call it as an acute exercise, acute effect of the blood pressures to the exercise. Even if you find a 2 to 3 drop in systolic blood pressure without changes in the diastolic blood pressure, that itself is a good sign. Not necessary that diastolic needs to drop, but the diastolic should not rise. If you get that there is a drop in systolic, but unchanged or without any change in the diastolic blood pressure, that itself is a good sign in the resistance to hypertension. We can usually by 3 to 6 weeks of duration, we can focus on this relaxation exercise, control the sympathetic tone, and then go for the other mode of exercise. It will work very well. We have seen 1 or 2 patients because they are usually having a very high sympathetic tone, looks very anxiety, resting heart rate is very high. Suddenly, the blood pressure is also even a small activity suddenly abruptly increases the blood pressure. In those cases, this type of synchronizing breathing with the relaxation exercise works very well. I did not focus on the yoga. I did not focus on the Pilates and other aspect. Today, since my topic is only on the exercise and physical activity, I have highlighted only these 2 approaches. Otherwise, there are various other methods by which you can able to non-pharmacologically you can manage the hypertension also.
Thank you, sir, for your all this information and the answers to the questions. Over to you, Dr. Ankita.
I think Dr. Ankita is you are muted.
Sorry. Yeah, thank you, sir. That was my question. The last one was my question, and if it is okay, I would just like to clarify one thing. That my question was basically when the person is undergoing ABP monitoring, ambulatory blood pressure monitoring. So at that time, is it good to encourage them to check their response so that once the report is there, we have a submaximal response to exercise? And is it okay to prescribe exercises based on that?
Yeah, ambulatory blood. Yeah, this is okay. It's a good question. Ambulatory blood pressure. The purpose of doing is to understand the hypertensive mechanism in different aspects. When you are at rest, what is the nature of your blood pressure? When you are in sleep, what is the nature of your sympathetic and the parasympathetic activity? When you are performing your routine activity of daily living, what is the sympathetic and the parasympathetic activity? In those cases, normally what we suggest them is in the 24 hours, you continue to do your all routine activity. If they're going for a 30 minutes or 45 minutes of walking daily, if they're going, they no need to stop that. They are allowed to do that. And we have to understand and we have to monitor the blood pressure responses in different level of their lifestyle, in terms of the sleep, in terms of the See, when you take sleep, predominantly the parasympathetic comes into the picture. When you start doing the activity, sometimes initial phase, the sympathetic tone becomes more predominant. So you wanted to understand basically the autonomic function, because see, why we are measuring is cardiac arrhythmia is one of the most common risk in those patients. To understand the arrhythmia, you need to understand the autonomic function. Therefore, it is allowed to ask them to do their routine activity. Whatever they are practicing, that they need to do. On that particular day, they should not restrict their activity. Hope I am clear with your question.
Yes, sir. Thank you very much for clarifying it. So thank you for taking out so much time for this day, and the Society of CVPR is thankful for your time and in-depth knowledge that you shared today in your presentation. So not only from pathological point of view and just exercise prescription, but physiologically how it will help, and going right up to the molecular and cellular level. So that was interesting and amazing to understand. I hope all the participants who are attending this meeting today would, especially the younger lot, the students, would be happy to learn all of this, and probably they don't have to go back to the books and read that much. You've given such a detailed presentation. We know that you are very, very busy, sir. Still, we would like to, see you more often in these kind of events, and we would love to see you on our Society of CVPR website as one of the active members as well. So I urge to you from the whole team of Society of CVPR that, Maria ma'am also would like to put in few words. Ma'am, please go ahead.
I just want to thank sir. That sir, it's been wonderful, and right from micro to the macro level, and the way the changes and the structure and the scientific and the evidence base that you have taken through, giving so much volume of information that is available, and exactly what to choose and how to put it forward. It's been a great insight for everyone, and it's always wonderful to hear you. So we look forward to many more such interactions in the future, and hope to take things forward with CVPR Society to get the message across, get the vision across, connect all the dots across India, and bring it all to one. And I'm so grateful to you for having accepted this invitation on such short notice and really relaying it through. Thank you. Thank you very much, sir.
Thank you, madam. Thank you, Dr. Sudeep. Thank you, Dr. Ankita.
We need one photo.
It will be honor for me to be a part of the society also. Thank you all.
Yeah, so one photo that we'll take group photo for everyone. So if everybody can just put their video cameras on, then Moinesh can take the photo.
Sure. Just let me know when to click.
Yeah, please everyone, can you just put your video cameras on so that we can have the photo? Sudeep, your camera on, please.
Just a minute, ma'am.
Moinesh, just see and click. Maybe you'll need 2 or 3 shots. And we need to thank Moinesh, who's been handling the things which whenever we have online Zoom meetings, and all our society members who, basically all work together unanimously. Sir, we have a great working team. They all come together when we have an event. Okay.
Thank you. Let me take one more pic. Yeah, done. Thank you.
Okay. Thank you. Thank you once again. Thank you so much.
Thank you all. Just see you all. Just bye.
Thank you. And I think this is the best way to celebrate this day, by increasing awareness amongst physios.
Yeah.
Thank you. Thank you all.
Thank you, sir. We take leave, sir. Thank you. Moinesh, your recording, you'll have to revert it, right?
Yeah. The recording will stop as soon as we'll end the meeting.
Okay. So you can end the meeting. Yeah.
Should I end the meeting?